Hello, everyone, and welcome. Thank you for joining this session. Thanks for joining this session on uncovering covert pathogenic bacterial burden in surgical site wounds with point-of-care fluorescence imaging. We are thrilled to have with us both Dr. Kylie Sandy-Hodgetts, who's an associate professor at Murdoch University in Perth, Australia, and she's also the president of the International Surgical Wound Complications Advisory Panel, as well as Dr. Charles Andersen, who's chief of the wound care service out at Madigan Army Medical Center, where he's also medical director of the wound care clinic, and he has been using this device to look at surgical site wounds as well. So just a couple of disclaimers before we get started. You can see them here. I just want to mention that the opinions expressed in this presentation are of the authors. They're not that of the U.S. Army. And if you'd like any information on the indications for use of the MolecuLight, our U.S. indications for use are listed here. And with that, we will get started.
G'day everybody, and thank you to MolecuLight for the opportunity to talk to you today about, or this evening, about the use of fluorescence imaging in surgical site infection, and also to my fellow esteemed colleague, Dr. Charles Andersen, who will be sharing clinical experience with this amazing diagnostic device. But did you know there's over 313 million surgeries performed annually around the globe each year? That's quite a considerable volume of surgery. And usually what happens when you create an injury to the skin through an incision site, you have an inflammatory response to the inflammatory cascade, and you can anticipate normal wound healing in a healthy individual and full closure between 6 to 8 weeks following the surgery. Now, what we do know is that a lot of our patients that we're dealing with is not necessarily the normal healthy individual. We're dealing with individuals that have chronic comorbidities, pre-existing disease states, and therefore complications, unfortunately, do occur following surgery. Now, there are a number of definitions for these types of complications, but surgical site infection is the one that's most commonly used. And even though we have advances in surgical technique, intraoperative practice, and a growing menagerie of wound care dressings, the incidence of surgical site infection continues to rise, particularly in low to middle income resource settings and those with restricted access to education and resources. And this table is from our recent publication in the International Wound Journal. It just shows you a snapshot of the incidence of the rates of surgical site infection worldwide.
Thank you, Kylie. So, as Kylie just stated, surgical site infections remain a very significant problem. So when you think of surgical site infections, obviously you start with bacteria, so a contamination that can present or progress to colonization, local infection, and spreading infection, and obviously can if it goes the full course, can cause significant morbidity and even mortality. Unfortunately, when you depend on clinical signs and symptoms alone, you don't really have the opportunity to make a diagnosis until you get to a local infection. Having the ability to identify bacteria in a wound at the point where you're at the colonization state gives you the opportunity to then intervene and prevent the progression of the surgical site infection. So that's what we're going to be talking about with the fluorescent imaging, is the ability to identify bacteria early, make the appropriate treatment, and prevent the progression onto a serious wound site complication. So this is from the FLAG trial. This was a multi-center trial. 350 chronic wound patients were analyzed. Those patients all had a clinical evaluation and then a plan based on the clinical evaluation alone. Then they had the imaging for bacteria, and that changed the plan significantly, as we'll see in future slides. What they found in that study was that 82% had bacterial loads greater than 10 to the 4th. So that not only included surgical wounds, which we're talking about today, but also venous leg ulcers, diabetic foot ulcers, and pressure injuries. So chronic wounds have a significant incidence of bacterial burden, 82%. And if you depend on clinical criteria alone, many of those are undetected.
So what we found in the following the FLAG trial is a post hoc analysis, and it's fairly clear that bacterial loads that are greater than 10 to the power 4 are shown to delay wound healing and increase the risk of infection following surgery. As president of the International Surgical Wound Complications Advisory Panel, or ICECAP, we have a number of initiatives that's highlighting the need for more objective diagnostic techniques that support early and accurate bacterial detection. Really, the earlier we pick this up, the more accurate we are at it, the further we can go in improving outcomes by preventing a wound from escalating into something a little bit more catastrophic. So could we use this type of technology to identify the burden in incision sites and to identify at-risk wounds and intervene before the infection manifests?
So this is the device that we're talking about. It's using the fluorescent imaging to illuminate the bacteria burden. So it's a handheld device for those of you that may not have had the opportunity to use this technology. No injection is required. It can be easily incorporated into the flow of a wound care clinic, as we'll talk about in a few minutes. So what you see is initially an image is taken, and then the lights are turned down, and then the fluorescent imaging is taken. And what you see on the examples is the red and cyan indicate greater than 10 to the 4th bacteria. So we use this device frequently. In fact, essentially every patient that comes into our wound care clinic, in addition to a thorough clinical evaluation, has fluorescent imaging. And we use this for guided debridement. So once we can see the presence of bacteria, if we can't clear that with just cleansing, then we go ahead with a debridement, trying to remove that infected tissue. So what you see pre-debridement, you see only a small area of fluorescence, but a significant callus underneath that. And when you remove that callus, what you see is significant bacteria under that callus. And here we're debriding that bacteria. So this is fluorescent guided debridement, which we use very, very commonly in our clinic.
Thank you for sharing that, Dr. Andersen. It's really great to see it in practice. And I guess from a research perspective, what we really want to know is how often do surgical wounds contain high bacterial loads, and how it kind of corroborates the whole story about clinical signs and symptoms of infection, which is what we use currently in clinical practice. But moreover, how can fluorescent imaging be used to detect bacterial burden in surgical wounds, and what's the clinical utility of this new technology? Following the FLAG trial is a post hoc analysis of data collected as part of a multi-site clinical trial. And what we found is that in 58 surgical site wounds, they were referred to specialists, and we compared FL and CSS. What's interesting about this study is that we use minimal exclusion criteria, which represents real-world data. So the clinical workflow during this study was clinical assessment. So that is using standard clinical signs and symptoms, positive or negative, of wound infection. And that is using the International Wound Infection Institute checklist. So 3 or more symptoms verify that a wound is contaminated and there is an infection present. Following that was a fluorescent imaging of that wound site immediately after assessment. Also to corroborate the story was a microbiological testing. So biopsy and quantitative culture analysis of total bacterial load using specific techniques was used to corroborate the story further. What did we find? It was very interesting that wounds with high bacterial burden presented with clinical signs and symptoms. 76% of the surgical wounds had elevated bacterial loads. So that is in excess of 10 to the power of 4. Interestingly, only 7% of those were diagnosed with infection using standard clinical signs and symptoms assessment. This is really quite a striking finding. What was also found was that multiple CSS were rare in surgical wounds. So essentially what we traditionally expect for a wound to be infected were not presenting. However, when fluorescence image was used, we could see the bacterial burden in that incision site. And here you can see the more common or overt symptoms that are used in standard assessment: erythema and swelling, pain and delayed wound healing. So it's quite interesting to see that CSS plus FL can actually improve diagnostic techniques.
Very interesting statistics, Kylie. Obviously, colonization progressing on to bacterial burden greater than 10 to the 4th, as you presented, is very, very common. And unfortunately, clinical evaluation alone does not pick this up. So these are some examples of fluorescent imaging results. And what you see on each example is a picture showing the wound. And when you look at that wound, very low likelihood or suspicion that there's any bacteria. But when you do the imaging, what you see is 2 areas of fluorescence in that wound. If you're going to do a culture, for example, you now know where to culture. In addition, when we see that, then we would proceed on with debridement and removal of that area of bacterial burden. Again, the next slide, similar, you look at a vertical incision, no real clinical signs of surgical site infection, but again, on the image, you can see the example of bacterial burden. The first slide on the bottom is something that we see commonly. So this is a wound with callus around the wound, and you see that the bacterial burden is in that callus. Now, this is something that we would debride. Many times when we debride that callus, there's additional bacteria underneath that callus that requires even additional debridement or cleansing to remove that bacteria. In our practice, we aim to remove all of the bacteria either with cleansing or with debridement during that episode of care. The next one, again, a diabetic foot ulcer, low likelihood using clinical criteria alone that you would suspect a significant bacterial burden. But as demonstrated in the slide, again, a very significant bacterial burden that requires significant debridement and cleansing to remove. So when you look at the ability to make that diagnosis with clinical signs and symptoms alone, that's 6.8% compared to fluorescent imaging, that is 77.3. So the fluorescent imaging 11-fold more sensitive than clinical signs and symptoms alone. So it really gives you the ability to make that diagnosis, bedside evaluation, and then appropriately treat that, as I've emphasized.
What's really interesting about this study finding is that although pathogenic bacterial burden is present in the majority of these wounds that were referred to wound specialists, only 7% picked this up through CSS alone. It's really important to realise that the sensitivity and specificity of this particular technology is 11-fold more advanced than using clinical signs and symptoms alone. And also, when clinicians had experience and training in the use of this device and the interpretation of images, it improved their diagnostic accuracy. But how can we use this type of information to help our patients? Dr. Andersen.
Yeah, this shows me in the clinic with a patient that we're doing fluorescent imaging. I'd like to go through how we use this in our clinic. As I mentioned, we do an appropriate clinical evaluation, and then following that, essentially all of our patients get fluorescent imaging. If that's negative, that's helpful also. So again, when you're talking about the selection of dressings or the ability to use advanced techniques like skin replacements, biologic tissue, you want a clean wound that does not have bacteria. We work very, very closely with our plastic surgeons, and before they do any kind of a split thickness skin graft or a flap, again, we want a wound that's clear of bacteria. If the scan is positive for bacteria, then, as I mentioned, we will try to clear that in the clinic. And we do that with initially a very thorough cleansing of the wound and then debridement. Most of the time, using the cleansing and the debridement, we can clear that wound and the surrounding tissue of bacteria. We had another paper that we presented or published, and that was cellulitis associated with chronic wounds. So in a small subset of patients, what you see is outside of the wound, you see a subdermal collection of bacteria that cannot be cleared. So in that instance, we add a short course of antibiotics and are able to clear that. One of the areas that, although it's not a surgical site infection, it's been very, very impressive in our practice is pressure ulcers. So we've just completed a study looking at pressure ulcers, and pressure ulcers that come to our clinic. So these are established pressure ulcers. 80% had a bacterial burden greater than 10 to the fourth with the fluorescent imaging. Having the ability to know that at your initial visit and clear that bacteria, most of the time, again, with debridement and cleansing, and at times a short course of antibiotics, we've been able to prevent that entire cohort of patients from progressing on to deep wounds requiring hospitalization, and the majority have progressed on to healing. So it makes a real difference that you're able to identify that bacteria, treat it when initially seen in the clinic, and that changes the healing ability of those wounds to heal. But more importantly, it prevents that from progressing on to a very serious infection requiring additional therapy and at times hospitalization. This particular picture that you see, I was actually talking with the patient. And this is the other advantage, and I think a real important use of this technology is to show the patients and talk to the patients about what you're seeing in the wound. This patient, again, we were having a conversation, and I made a quote with this slide. He said, "Well, now I understand how serious the wound is and why we are having to debride and do the therapy that you've suggested." So making the patient a part of that clinical visit, I think they understand and they become much more compliant. It's very interesting when we have a patient come to the clinic and we're going through our clinical exam. If for some reason we're in a hurry and all of a sudden we don't scan the patient will say, "Aren't you going to scan me?" So they understand and they appreciate the information that we can get. So it's very good for patient education and promoting patient compliance. This is an example of what I think is very, very important. So I'm a vascular surgeon by trade, and vascular surgeons, if you get a surgical site infection that progresses on to involve a graft, that's a major, major complication. Can require very serious additional surgery, and it carries a significant morbidity and even mortality. This is an example. So we have we work in a limb preservation initiative. So we have vascular surgeons, wound care, and advanced podiatric care. So this is a patient that had a podiatric procedure with the insertion of hardware. So when you look at the incision, there's a little erythema around that, but no real clinical indication of a surgical site infection. You can see the fluorescent imaging clearly showing a collection of bacteria. So a small incision was made in that incision, drained an abscess, put that patient on antibiotics, and did appropriate local wound care. What's very, very important is that this wound then healed without infecting that hardware. So when you're dealing with orthopedic procedures, with implantation, vascular procedures, any procedure where there's a foreign body, if that gets infected, that's a major complication. So having the ability to make that diagnosis before you get the deep infection involving that graft or hardware is very, very important and shows the value of that fluorescent imaging in surgical incisions.
Thank you for sharing, Dr. Andersen. And I think what's exciting about this is this novel technology can really advance practice for detecting infection quite early on, but it can also inform antimicrobial stewardship policies within your hospital or clinic department, or even whether you would prescribe antibiotics for your patient based on what you're visualising, what you can see. After you've cleansed the wound and there's good wound hygiene, then you can really see what's happening in the wound. So I think this technology is really shifting the management paradigm for surgical incisions from reactive to proactive. Would you agree, Dr. Andersen?
Absolutely. Very proactive instead of waiting for a very serious complication.
Thank you so much to you both. What a fantastic presentation. And I see some questions have come in, and we're going to get to the questions. I will direct people to the MolecuLight booth if they want a copy of this publication on the surgical site infection study from the FLAG trial, or any other questions. The first one that's come in is about pricing of the device, and I know this is a very international meeting, and so I do direct you to the MolecuLight booth at this meeting for any questions about pricing. The team there can get you something specific to jurisdiction. So in terms of questions, Dr. Sandy-Hodgetts, I know you are president of the Surgical Wound Complications Advisory Panel. So what are some key leverage points for preventing complications in surgical wounds that you think this technology could potentially interface with?
Great question, Monique, and thank you so much. Look, I think what's key for prevention of surgical wound complications like surgical site infection is early detection. We have a best practice statement we published 2 years ago now. And one of the key statements is picking it up early. It's really simple. So it's about monitoring that wound in the home care setting, and also being proactive in the post-discharge surveillance of surgical wounds. What is fantastic about this technology is it's so easy to use. You visualise the bacterial burden, if there's any, in the incision bed, along the incision line, and in the peri-wound skin as well. Because as we know, the flora, not only the skin flora, but any contaminants such as staph or Pseudomonas, you'll be able to visualise those using this device. So it's really shifting or turning on its head standard wound management for incisional wounds. If we can see it, we can treat it, we can cleanse the wound, check again, and then either initiate antibiotics or something that's a bit more specific to management of infection in wounds. It's accuracy and early detection.
Fantastic. And Dr. Andersen, a question for you. I understand it can be difficult to identify some of these signs and symptoms of infection, like erythema, especially on a darker skinned patient. And so can you comment on whether or not this technology might help to address some of that limitation of your assessment when there's a darker skin?
Absolutely. So this technology is useful in all skin types and gives you, again, the ability to extend your clinical evaluation, knowing that using clinical signs and symptoms are very limited. So we're very liberal in looking at incisions and picking up early surgical site infection.
Excellent. I recall that in the FLAG trial, the larger version of the trial, the 350 patient version of the trial, Fitzpatrick scale is something that was looked at in that study and was able to show that there was no difference in detection ability across the skin tones. So it wasn't something that was hindered with the higher melanin content. So that's great to see. Dr. Andersen, how has this technology impacted your use of antimicrobials and antibiotics? I know you talked about your cellulitis work, but in general, have you been able to lower, would you say, your antibiotic use in your clinic?
Yes, I think having the ability to identify the bacteria and, in the great majority of cases, remove that with cleansing and debridement, then those patients are not placed on antibiotics. So I think it contributes to appropriate use of antibiotics, good antibiotic stewardship.
Good. And I see a question that's come in, and I'll actually take this one. It's whether all bacteria fluoresce, and that has been extensively tested, and gram positives, gram negatives, aerobes, anaerobes, all are fluorescing bacteria. There are a couple of species that do not produce the porphyrins that the device detects. including streptococcus, but the vast majority of bacterial pathogens do fluoresce under this device. And you saw some examples of Pseudomonas, which uniquely produces that cyan color on the images. And sadly, that takes us to the top of the hour, and so we need to end the session. But I'm so appreciative of you both for getting on and describing this important study and sharing your findings from the clinic as well. Thank you so much.
Thank you.